Sudden onset white cataract in a young patient. Pause the video here to review details. The first surgical challenge in this case is creation of a continuous curvilinear capsulorhexis using phaco-decompression techniques in trypan blue. We use the 27-gauge needle bevel up on a BSS syringe to pierce the capsule and remove some intumescent lens milk, and we saw a surge of fluid from the main wound and capsule, a warning sign for the Argentinian flag. This patient's a diabetic with a history of many injections. The pathophysiology of his cataract have led to development of intumescent lens fluid and intralenticular pressures which are greater inside the lens than outside the lens, causing the runout rhexis that we colloquially term the Argentinian flag. We've just spent the last couple seconds using intraocular scissors and neutrata forceps to gently open up the anterior capsule, creating enough space for this lens to get out of what's left of this bag. Now nuclear disassembly will be accomplished using different fluidic settings, including lower aspiration rates, or flow, and lower IOP. We'll keep the chamber as stable as possible while removing the nucleus in a modified trivide fashion to split the nucleus into V-shaped segments that can be pulled out of the bag into the iris plane for low energy aspiration. The video is at double speed for the key details of the rhexis and about 4x speed for the rest of the case. We're now introducing the chopper to begin gently separating our V-shaped grooves into smaller segments, decompressing the lens even more and helping to stabilize your capsular bag. Of course, in pre-op, it was clear that this case was high risk. Rapid development of a white cataract after injections makes us think that the posterior capsule may not be intact, and at the slit lamp we could see a blue tint to the lens indicating higher chance of intumescence. The patient was informed that this case could be complicated, there was a higher chance for 2 surgeries, and the patient was also consented for possible anterior vitrectomy. Now we're almost finished dialing the last segment of the lens out and eating it up, keeping the chopper in the safe position below the phaco tip. One of the perks of this case is that the axis is clear, so we deferred cortical cleanup in this case to avoid radializing our anterior capsule posteriorly. We placed a single piece acrylic lens in the intact bag, one half at a time, placing the trailing haptic into the eye with a Sinskey hook to minimize stretching forces. We see the IA tip removed with bimanual irrigation to keep the chamber and lens as stable as possible after a gentle removal of some cohesive viscoelastic. We did leave some OVD in place to avoid instability of the chamber. We sealed our wounds, checked our pressure, and gave Myostat to ensure the lens stayed put, and gave the patient subconj dexamethasone and PO Diamox to prevent inflammation and high pressures. Here's a brief segment of surgery from the patient's fellow eye, starting with a similar approach, 27-gauge needle on a BSS syringe, bevel up to make a small hole in the anterior capsule. Next, we'll take our ball tip chopper and gently ballot on the anterior capsule to help evacuate pockets of intumescence beneath it. Then we'll take our phaco tip in the sculpt setting in positions 1 and 2 to remove even more fluid. With soft pressure on the nucleus, we can help evacuate hidden fluid from behind the lens controllably. This was about case 70 for me as a trainee, and it's now apparent that the rhexis is quite small. The rest of the case went normally, and the nasal snip in the capsule was created to prevent phimosis. And this patient went from hand motion in the right eye, 2400 in the left eye, to seeing 20/25 both eyes. Thank you guys for watching.